Hello everyone. As part of our Perspectives webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar, Current Strategies for Vascular Access Device Stabilization, INS Standards of Practice. And now I'd like to introduce you to Mary Alexander, who is our moderator today. Mary serves as Chief Executive Officer of INS and INCC. As INS CEO, she is responsible for the management of an international nonprofit specialty nursing organization of more than 6,000 members. As INCC CEO, Mary oversees the Certified Registered Nurse Infusion Credentialing Program, and she works with other nursing organizations in the U.S. and worldwide to further the knowledge of and the practice of infusion therapy. Mary is also editor of the Journal of Infusion Nursing, INS's scientific, research-based, peer-reviewed publication. Mary, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this important webinar for so many people today. Are you ready to get started?
Yes, I am, Emily. Thank you, and thank you for that nice introduction. Good morning and afternoon to everyone, and welcome. It's my pleasure to introduce our speaker, Lisa Gorski. Lisa has worked for over 30 years as a clinical nurse specialist for Wheaton Franciscan Home Health and Hospice in Milwaukee, Wisconsin. She is author of over 50 journal articles on home care and infusion therapy-related topics. She is past president of INS and is currently the 2021 INS Standards of Practice Committee Chair. In 2006, she was inducted as a fellow in the American Academy of Nursing. Lisa was named the 2003 CRNI of the Year by INS and the 2011 CNS of the Year by the National Association of Clinical Nurse Specialists. She has spoken nationally and internationally on standards development, home health care, and home infusion therapy. Lisa has disclosed the following relevant financial relationships: as a consultant receiving a speaking honoraria from BD, 3M, and Genentech, and an advisory board member for Teleflex, IV Watch, and Hospira Pfizer. This activity has been approved for 1.0 contact hours of continuing education. At the end of this webinar, you can obtain the continuing education credits. The URL will be provided at the conclusion of the webinar. And as you can see, these are the accreditation statements. I also want to point out that this activity is supported by an education grant from Dale Medical Products, Inc. Now, I'd like to turn this over to our speaker. Lisa, are you ready to get started?
Yes, I am, Mary, and thank you for that introduction, and welcome to today's webinar. It looks like we have really good attendance, so obviously this topic is of interest to many of you, obviously. The title is Current Strategies for Vascular Access Device Stabilization, INS Standards of Practice, and I will be focusing, of course, on the INS standards, but taking it a little bit beyond, looking at some of the research that's been done since we last published the standards in 2016. We've actually begun the work for the 2021 standards, having just had our committee meeting in September of this year, and we'll be doing intensive and comprehensive literature reviews on all of the topics that we address in the standards in terms of formulating the new recommendations. Okay, so the objectives for today's presentation are to describe methods of vascular access device or VAD stabilization, to identify the advantages of stabilization, to identify appropriate methods for stabilization based upon patient characteristics, and evaluate research evidence supporting stabilization. And as I mentioned, we'll go beyond the research that supported the 2016 standards. All right, so as you listen to my presentation today, I think there's key questions that we need to think about in our own organizations, whether you're working in acute care, outpatient services, home care, perhaps skilled nursing facilities. But once that vascular access device is in place, whether it be a peripheral catheter, a central line of some sort, a midline catheter, midline peripheral catheter, how is it best managed? What are the key aspects of care? How can we reduce the risk of complications? And how can we ensure that that vascular access device remains in place complication-free optimally for the patient's infusion therapy needs? So these are things that we need to think about. If we look at short peripheral catheters, or SPCs, and this is the terminology that we use in the Infusion Nurses Society to really differentiate that, typical short catheter that's placed by the average nurse out there as well as infusion teams, and differentiate that from, say, a midline peripheral catheter that's usually placed by nurse specialists or clinicians, not necessarily always nurses even, but so we differentiate that. And when we think about that short peripheral catheter, we have to recognize that really the majority of patients in hospitals are going to receive at least one peripheral catheter. And because they're so common, I would assert that we often underappreciate and underestimate the potential impact of common complications. And this has really been a common thread of discussion and updated literature, the concern about failures associated with the short peripheral catheter. I'm just going to highlight a couple of studies here, and this actually was more of a literature review by Hellman Associates. It was published in the Journal of Infusion Nursing in 2015, and it was titled in a very so-called catchy way, Accepted but Unacceptable Peripheral IB Catheter Failure. And this article really has received a lot of attention, but they speak to the fact that the failure of peripheral IB catheters, that it's disconcerting that even the most rigorously performed studies indicate that the overall IB catheter failure rate lies between 35 and 50%. Failures take the form of phlebitis, infiltration, infection, accidental dislodgement, any of which alone or in combination leads to removal of that catheter before we would really want it to be removed. And if we look at some of the consequences of, say, these complications, they may be bleeding, hematoma formation, extravasation, thrombophlebitis, and even catheter-associated bloodstream infection. So it is a significant problem. And then I thought I would highlight a more recent study that was published in 2018. And this was an Australian study. It was done in a tertiary care hospital, and they looked at 1,000 patients and followed them prospectively. And that involved over 1,500 peripheral IV catheters. And they established a rate of 32% peripheral IV catheter failure, 17% phlebitis, 14% occlusion and infiltration, and 10% dislodgement. Clearly, we need to look at, can we do better in terms of managing those peripheral IV catheters? So let's now take a look at central lines. I'm really going to just focus on PICS because there's more data there. And I pulled a 2017 study. And in the review of the literature for this study, they looked at, failures of PICS and found rates of up to 40%. Now, one of the key clinical concerns that was addressed in this particular study was catheter migration, and speaking to the fact that if that catheter does get out of place from its proper tip placement in the lower superior vena cava, and that can lead to infiltration, extravasation, thrombosis, or unintentional dislodgement. Obviously, there's different etiologies for all of these, but certainly catheter migration is a potential problem. Now, the focus of their study was to look at dressing and securement methods, hypothesizing that they if we do them effectively, they should prevent dislodgement, migration, and we know we can't always prevent some of the internal catheter malpositions that happen, but we can certainly reduce that risk of accidental dislodgement and minimize that micromotion within the vein. So in this study, it was really a pilot randomized study, and it was really a feasibility study looking at the fact, could we do a larger randomized controlled study on this topic. And basically what they did is they looked at 124 picks. They were randomized to 4 groups. One was just a standard transparent dressing with a adhesive-based type of stabilization device. One was basically a dressing with just tape. One was a combination securement product where the securement is actually built into the dressing, and one of the groups was the use of a tissue adhesive or a glue in terms of stabilizing the catheter. And basically the overall most common failure was dislodgement at a rate of 6%, which doesn't seem very high, but certainly it's something that we could prevent. And they established that it was feasible to do a large study. They did actually pull out the assignment to the group with just tape and just a transparent dressing because of the risk of dislodgement right off the bat. So they're looking to do a larger study of these particular options. So obviously there is a lot of interest in how can we better secure these catheters. Now, we think about this from the nursing perspective, but we have to really consider the patient perspective of failed vascular access devices and think about it from the perspective of is it your husband or wife or your parents in the hospital? Will they have to endure pain and discomfort, potentially the need for additional treatment, say if they had a severe infiltration or extravasation, if they continue to need infusion therapy, need for repeated needle stick procedures, whether it's a repeat of a PICC placement or a repeated peripheral IV catheter. So the ultimate receiver of these bad outcomes is the patient. And of course, as nurses, we are really concerned that we do the best job for the patients that we care for. So if we take a look at preventing vascular access device complications, I'm just going to talk about some of the general things that we need to consider in terms of pre-insertion. Nothing comprehensive in this slide, but just think about the fact that, it begins with the planning of the vascular access device, putting in the right device to meet that patient's needs, preparing the patient and doing the patient education as appropriate, based on the patient's condition and needs at the time of admission to whatever facility that patient is in. Consideration for the use of vascular visualization techniques such as ultrasound, which can really improve success rate in patients who have difficult venous access. Attention to site preparation, skin is clean, proper skin antisepsis, so we're not we're minimizing the potential tracking in of microbes on the skin into the venous circulation. Aseptic technique during the procedure, selecting the best device in terms of gauge, site selection, avoiding those areas of flexion, for example, and of course the dressing and stabilization, which is obviously a focus of this presentation today. So if we look at post-insertion, perhaps you're not placing that catheter, perhaps you're just taking care of it after it is inserted. Then we have a number of things that need to happen to reduce that risk of complication, protecting the site. And this really refers, when we talk about it in INS standards, to protecting it from inadvertently having the patient pulling it out if they're confused, or protecting that site of that pediatric patient from playing around at that site. Stabilization of the joint if necessary. We definitely recommend to avoid placement of a peripheral IV in areas of flexion such as the wrist or the antecubital. There are situations where this does happen, but then we need to stabilize that joint. Aseptic technique with every entry into that catheter, attention to that needleless connector disinfection, which I think everybody is really aware of, but we might not be always doing consistently, maintaining the patency of the catheter, an intact dressing, ongoing assessment, and of course stabilization, which is the focus of today's presentation. So before I begin talking about that, I think it's important to just review kind of basic anatomy pathophysiology here. Again, I know this is a review for most of you, but I think it really makes sense to just spend a couple of minutes here thinking about this. This is something that I cover in the orientation classes that I do with the nurses in my organization. And I think when you understand rationale, it just makes a lot more sense. So if we look at our vein, and I've got a diagram there, and it includes arteries as well. But we've got 3 layers of the vein: the outermost layer, the tunica adventitia, or sometimes called the tunica externa, the outermost layer, loose connective tissue, elastin fibers, includes the vasa vasorum, which supplies blood to the vein, the tunica media, that thick layer of connective tissue with elastin and smooth muscle fibers, and then of course the tunica intima. And when we recognize that the tunica intima consists of a single thin layer of endothelial cells that allows blood to flow easily, we recognize that this layer can be easily damaged by a number of factors related to IV insertion and IV care. For example, if we advance that catheter too rapidly, or we use a large catheter in a small vein, if there's catheter motion due to a lack of stabilization, all of these things can cause irritation to that endothelial layer, which is going to lead to the complications such as phlebitis and infiltration. So when we talk about catheter movement within the vein, that's most often referred to as pistoning. We know that repeated movement does lead to that endothelial injury. It's a mechanical cause. When we look at the cause of phlebitis, we look at mechanical, and we look at infusate causes, but a mechanical cause because there's irritation due to the movement of that catheter. Fibrin and platelet deposition can lead to thrombosis at that catheter tip, and perforation of the blood vessel can actually occur as well, and this can lead to infiltration and extravasation from this endothelial injury. I pulled a quotation from a recent clinical article by a well-known researcher who states that even the smallest IV movement causes irritation, pain, thrombosis, and swelling of the vein. So I think this is something that is really an important point within this presentation today. I also pulled a statement from researchers, DeVries and colleagues, who have put together in their organization, and they've spoken widely on this topic, a protected clinical indication bundle. As they looked at extending their short peripheral catheter dwell times, they put together a bundle of key interventions, and they've been quite successful in extending their dwell times with their bundle. Now, they did include a securement dressing as part of their bundle because it's a strong element, and this is their verbiage, in preventing catheter pistoning within the vein. So let's take a look at INS standard number 37. It's entitled VAD Stabilization, and the standard statements are broad statements that are considered really a fundamental standard. It states, stabilize and secure vascular access devices to prevent VAD complications and unintentional loss of access. So we're really kind of looking at 2 things here to prevent that micromotion and pistoning within the vein itself, and to maintain the VAD within the vein. In other words, really keep that catheter from accidentally dislodging. Now we'll take a look at some of the practice criteria as we move on here. And the practice criteria in the INS standards are the second component. Each standard consists of a broad standard statement and the practice criteria. And the practice criteria are really the evidence-based recommendations under that standard. And we recommend to consider use of an engineered stabilization device, or an EST, we do use that acronym, to stabilize and secure VADs, as inadequate stabilization and securement can cause unintentional dislodgement and complications. They further state that the ESDs promote consistent practice among all clinicians, reduce VAD motion that can lead to complication, reduce interruption of needed infusion therapy, and may decrease the cost of care. So all of the practice criteria are fully referenced in terms of recommendations. So what is an engineered stabilization device? We define that as a device or perhaps a system that is placed subcutaneously or topically. It is specifically designed and engineered to control movement at the catheter hub. So it's not just a plain dressing. It's something that is really designed to control motion to stabilize that vascular access device. So I'm just going to go through some of the stabilization methods here, and I have them grouped into 5 categories based on a recent article that was published in American Nurse Today by Spencer. Did a kind of nice job just doing an overview in a general nursing journal. So the first option is sutures. We do not recommend sutures for a number of reasons. Certainly there's difficulty in providing site care and skin antisepsis with the sutures in the way, and we certainly have risk for infection as well as healthcare provider needle stick injury. Oftentimes the sutures are tied too tightly. Multiple suture points can make skin antisepsis specifically difficult, and because you have that additional break in the skin due to the sutures, you have that potential for bacteria entering that subcutaneous tissue via the suture point. Then we've got subcutaneous engineered stabilization devices. This is actually a product that I have not used. I think it may be a little bit more regional, but I'm seeing more presentations on this topic and a little bit of more research out there. But what it is a small anchor that's placed just beneath the skin at the catheter insertion site. It's attached to the catheter shaft. It is not used with peripheral catheters. It's used with PICCs and sometimes internal jugular central vascular access devices. And I'll talk a little bit more about that on the subsequent slide. Then we have our adhesive-based engineered stabilization devices. These are very common stabilization solution. I'm not going to talk product names in this presentation. There are a number of products out there. Some have plastic, some have Velcro over an adhesive pad to lock that vascular access device. They're used in conjunction with the dressing, and you have to look at the manufacturer's recommendations, but they're generally recommended to be removed and replaced with each dressing change. You don't leave them on endlessly. And that has been a problem because some people believe that they can just stay there and just change the dressing, but you run that risk of microbial growth on the skin under and around that adhesive-based device, so they do need to be removed and changed. Then we have our tissue adhesives plus a dressing, and I'm going to talk a little bit more about that because it is a novel approach out there. It's a glue, and there's growing interest. Some of you may be actually using this in your organizations. I know there's some studies going on, and we do have pilot studies, and I will highlight a little bit more about them as we move along. And then lastly, the last category would be your integrated securement devices. And this would be an alternative to a separate dressing and a stabilization product. That it includes a bordered, semi-permeable, transparent membrane dressing that may often have an additional adhesive components that hold that VAD in place. So we have some unique products out there as well. So let's take a little closer look at the subcutaneous engineered stabilization devices. This again is that small metal anchor that is placed in the subcutaneous tissue, and it heals within 48 to 72 hours. And it really stabilizes the catheter in place. Now there are advantages to to the use of this type of device. There's no adhesive involved, so for patients who do have skin issues related to adhesives, that could be an advantage. It's very easy to perform skin antisepsis around the catheter insertion site, leading to less time for that dressing change procedure. The study that I've cited here, Goossens and colleagues from 2018, basically they did a randomized controlled trial that involved 105 adult patients. This was a study out of Belgium, and they really were looking at an outcome of dressing change time, and they met that. There was a significant difference in terms of that time to do that dressing change. However, the pain scores were higher in the patients who had this type of device, both at the time of placement and during removal. However, this can be, mitigated, and they talk about the importance of the learning curve to make sure that clinicians really understand how do you reduce that pain during placement and removal, and understanding that procedure. So if we take a closer look at the adhesive-based engineered stabilization devices, again, these are probably the typical things that many of you are using out there. Well-established stabilization method. A number of products are available. They do require education on how to use the products, and I think that's really important. As someone who's used a particular product for many years that I think actually works quite well, it does take some education and training to understand how to properly place that, how to properly remove it, and how to properly remove it without inadvertently moving that catheter out of its place. In fact, I just did a visit with one of our nurses with a patient who was requiring infusion therapy, had a pick in place with this type of stabilization device, and this new nurse had never used this type of product before, so it can be a little bit precarious. So I really do recommend that there should be competencies in place, whatever product you're using, to make sure that everyone understands proper use. And with the adhesive-based engineered stabilization devices, we also have a concern for MARSI, or medical adhesive-related skin injury, which I have a little bit more on a slide later. So let's take a closer look at the tissue adhesive. In essence, it's a glue. Okay, it's a medical grade skin adhesive. Now, the advantages to using this type of product is that it actually seals the insertion site, can provide hemostasis, and a barrier to microbial migration. So there's a lot of interest right now in this type of product. And when you use a tissue adhesive, it does take about 10 days to completely degrade, and you have to be very careful with removing it. Tissue adhesive removal agents may be required. So that's an important point. It's not, it seems very simple, and in essence it really is, but we have to have concern for the skin as well, and how if we're taking that catheter out before, after it's before it's completely degraded, that can be a concern. So education is required for correct removal to avoid that potential skin damage. Now, when you use a tissue adhesive, it's typically applied directly at the skin entrance site of the catheter, and also underneath the catheter hub. So if we look at tissue adhesives, there's been a number of early studies, and basically pilot studies, and they've been explored with their use with a number of type of access devices: peripheral catheters, arterial catheters, and I will talk a little bit more about arterial catheters coming up, epidural catheters, and central vascular access devices. And just to note that the references, if you want to take a closer look and read up on this, and you print out the handout that goes along with this, all of the references are fully listed there, so you can obtain them and read them if you desire to do so. So let's take a closer look at the INS standard 37. I shared a couple of the practice criteria with you, but not all of it, so we'll go through that. So when you're looking at making a decision for stabilization and securement, you want to think about the patient's age, their skin turgor and integrity, previous adhesive skin injury, any type of drainage from the insertion site. So these are all factors in terms of making that decision. And it needs to be more individualized. Sometimes I think we just automatically use what, a single product out there when maybe something different might be more appropriate for a patient. When you think about the patients at the extremes of age, the extreme elderly patient or that neonate who is particularly at risk to skin injury. We state very clearly to not rely on the dressing itself. That in what we're referring to is just a standard non-bordered transparent dressing or a gauze and tape dressing. There is no evidence really that supports their use in terms of stabilizing that catheter in place. And as I talked about one of the studies earlier, they actually pulled that out of their randomized controlled trial, just the standard dressing plus tape, because it was considered a problem in putting that patient at risk for inadvertent dislodgement. We also state to avoid the use of tape or sutures as they're not effective alternatives to a ESD. And I think there's variance out there. I would say that in our practice and, southeastern Wisconsin where I work and receiving, referrals for patients with PICS from a number of large hospitals, I would say that sutures are pretty rare, but I know there are some areas that still do that. But as I talked about earlier, they're not effective and they may increase the risk for an infection, a bloodstream infection. Rolls of non-sterile tape can become contaminated with pathogenic bacteria, although we have not been able to make any connection, research-wise from use of, such a product to infection, but we know they're contaminated. And I think back to my acute care days when I worked on a surgical floor in the surgical ICU, where we typically, had our stethoscope around our neck, and we would sometimes have a roll of tape, hanging on the stethoscope or put in our pocket, and we just use these from patient to patient. So I think we've come a long way in understanding that we can potentially transmit microbes from one patient to another when we're doing practices such as these. And again, the sutures are associated with needle stick injury, and this is laid out in OSHA standards as well. And the INS practice criteria continue to go on and talk about awareness of that risk of MARSI or medical adhesive related skin injury that's associated with the use of these adhesive-based products, and direct us to assess the skin when that ESD is changed and anticipate that potential risk for injury due to age, joint movements, and presence of edema. And I just, threw in an understanding of skin in older adults, a statement here that there's about a 20% loss of the thickness of that dermal layer of the skin, the middle layer between the epidermis and the subcutaneous layer. And that results in that paper-thin appearance, skin fragility, increased risk for injury. I'm involved oftentimes with working with, the older adult, much more so than with children. And even this weekend, I have both my mother and my father-in-law are 97 years old, and they have some real fragility of their skin with just the slightest bit of injury resulting in bruising and sometimes loss of integrity and bleeding. And when you think about that, think about that with the use of these types of adhesive products. They may be not the most appropriate strategy, or they may work okay, but we just have to really be aware of that. It is recommended that we use a barrier solution to the skin that's exposed to the adhesive, because this will help to reduce that risk of MARSI. But of course, we don't want to use tincture of benzoin. It causes such adhesion that it can actually, when you remove anything, cause damage. So we want to use a good quality barrier solution. So what about arterial lines? We don't talk a lot about arterial lines, but stabilization and securement are important to them as well. We know that they're an under-recognized cause of catheter-related infection. There's a need for rigorous and controlled trials addressing patient outcomes. So there's not a lot of literature out there, and I was trying to find any information that talked about some of the common problems in contributing factors relative to, placement, use, and maintenance of arterial lines. Particularly, we're talking about our radial arterial lines. And I did find one older study, 2002, but it was basically a national database from Australia. And they looked at, two separate areas of practice. They looked at the during arterial insertion, what kind of problems occurred, and stated in their data collection there that inadequate securement was a problem 69% of the time. 40 out of the 58 catheter problems that were reported related to inadequate securement. And during the arterial catheter line use and maintenance, dislodgement and inadvertent removal happened at a rate of 24%, so 60 out of about 249 cases. So dislodgement is a potential problem with our art lines. So I pulled a couple of the pilot studies, and these pilot studies were looking specifically at the use of tissue adhesive to secure that arterial line and to prevent failure. And they look specifically at arterial lines placed in the radial artery that would be used for your continuous blood pressure monitoring and blood sampling. Now there's a caveat here. These are studies that weren't powered for statistical significance. They were really done to determine and compare some initial effectiveness and suitability for a future large randomized controlled trial. So if we look at these pilot studies just very briefly here, the first study published in 2014, almost 200 arterial lines, they looked at the main outcome measure was arterial catheter failure. So it was really a composite of all the things that are listed on the slide there, from complete dislodgement, pain, infection, inability to use it for monitoring. And they found that the failure rate was 13%. And they did find, now again, this was not powered for statistical significance, but the failure rates were highest in just using a standard transparent dressing. Now the second study published in 2015, basically the same interventions as the previous study. Now they again found an overall failure rate of 13.8%, but making the point that these catheters, these radial artery catheters were only in place approximately 24 hours, and we still had a really high failure rate, really considering that. And they looked at the tested interventions, and all of them had a lower absolute incidence than the control group. And they looked at I think I didn't list that on this previous slide here. I did not. But what they used in terms of testing interventions, they used the tissue adhesive. They used a standard adhesive-based type of device, and then a designated, securement transparent dressing, a bordered dressing. So those were the four groups there. So all of the three actually performed better than just a standard non-bordered, non-secure type of transparent dressing. So it gives us a little bit of insight there that could we do a better job if any of you are working in ICU settings where you are caring for radial artery catheters, what is happening in your unit? Could we do a better job? So I anticipate they probably will be doing a larger randomized controlled trial based on the outcomes of these two pilot studies. Okay, so now we're going to go back to the short peripheral catheter. Okay. And this is a very interesting study. This was just published this year. It is a randomized controlled trial, and it involved over 1,800 patients, and this was in Australia as well. They have a large program of research out of Australia called the Avatar program, and it involved 2 hospitals. And what they did is they randomized patients to 4 groups: a tissue adhesive with a standard polyurethane dressing, so a glue, so to speak, the bordered polyurethane dressing, and an adhesive securement device, that we've been talking about, with a standard dressing, and then just a plain polyurethane dressing, non-bordered. That would be your control group. And their primary outcome for this study, I think this got divided here, the primary outcome was all-cause short peripheral catheter failure is a composite. So they're looking at complete dislodgement, occlusion, phlebitis, and infection. Okay, and overall 41% SPC failure, similar to some of the outcomes that I was talking about in the overview at the beginning of the presentation. And the major finding was that none of the 3 interventions was superior to the control. And how they looked at this was that based on a previous trial, they found 40% failure. And so they hypothesized that those 3 interventions, the glue, the standard bordered type of dressing, and the adhesive type of pad used with the dressing, should reduce risk by at least 10%, and that would be clinically significant. And they did not find that. Okay, now when you look at this particular study, and there's a lot in there, I've spent a lot of time really trying to analyze this study. Most of the insertions were done by nurse experts. This could be a limitation, could reduce the risk of failure. However, the data was consistent with previous studies with less experienced inserters. So the medium dwell time, for all of these catheters was 54 hours, so very, very short. They looked at, some of the generalizability of their results. Certainly it was a heterogeneous type of population. Patient population, many were at high risk in terms of age, obesity, multiple comorbidities. Post-insertion care was done by the bedside nursing staff. So it probably is somewhat generalizable despite being done, in another country, but I think it's something that we certainly would make sense to have some replications out there. So what they concluded, they looked at patient and bedside nurse satisfaction as well, and overall that was high, okay? But their implications were that we need effective, durable products, and at this point, why would you use something more expensive if it's not significantly different from using just the basics out there? So that's kind of where they were at, with this particular study. But I think there is a but. We can go back to the Marsh study. This was the prospective study of 1,000 patients that I talked about earlier in the presentation. One of the significant findings in that study is that any additional securements, and that wasn't really a focus of that study, but any additional securements were associated with significant reduction in occlusion, infiltration, phlebitis, and dislodgement. Okay, and that might include, additional tape on the tubing, using some type of tube dressing, some kind of additional product. And I think that, again, some of the conclusions here is, are there multi-product combos, or is there some type of bundle that might be more effective than a single product? Now, again, I didn't want to get into detail with some of the studies on extending length with clinically indicated, but if you look at some of the DeVries research out there where they have a bundle in place, and they're looking at higher level placement of the catheter, sterile gloves, attention to that securement, and a number of other things, they are getting extended dwell times without an increase in complications. So I think there's still, research to be done. I think we just need to understand that securement is really important, but it's important in the context of a number of other things that are going to help extend the length of that catheter dwell with minimizing complications. So I'm just going to summarize, some of the key points here. I believe that despite the research, saying that we don't really have a superior product, at least in the single randomized controlled trial, that stabilization of movement at that vascular access device site is recognized, and it is an important intervention in preventing complications and increasing dwell time. Certainly, if we can stabilize, we can reduce that risk for unintentional catheter dislodgement, and if we can reduce that pistoning movement of the catheter within the vein, at the site and within the vein, we really probably can reduce the risk for phlebitis infection and catheter migration as well. And again, as I talked about in the beginning, care and maintenance of these vascular access devices, this is a focus on a single factor, but there are multiple factors that are going to contribute to your outcome. And lastly, that we do recommend in our standards use of that engineered stabilization device that is specifically designed and engineered to control movement at that catheter hub. As we work on the 2021 standards, which as I indicated earlier, we are in the process right now, we will be doing a very comprehensive review of the literature in terms of making our recommendations on a multitude of topics, obviously, but this will be a key topic. It'll be interesting to see where we go, what type of research is going to be forthcoming, over the next year or so, and how we will perhaps alter our recommendations, strengthen our recommendations, or reword our recommendations for future. The evidence is really critical, and I think it's important for all of us to understand that we need this evidence to really drive our best practice. So I thank you all for attending today's webinar, and I look forward to any questions that you may have about the content that I provided. Thank you.
Thank you, Lisa. We want to thank you for your presentation. The information that you have shared will certainly help us all in our clinical practice and will definitely make a positive impact on patient care. This activity has been approved for 1.0 contact hours. You can obtain those continuing education credits by logging on to saxtesting.com/P. You will need to register on the test site and complete the evaluation form. Upon successful submission, you'll be able to print your certificate of completion. And I want to note this activity is supported by an education grant from Dale Medical Products, Inc. And now I want to thank everybody we've gotten a lot of questions for Lisa, and I want to also thank everybody for their attention and participation. So at this time, Lisa, I'm going to start with a question from Kurt. Are you ready?
I'm ready.
He asked, shouldn't all hospitals establish their own VAD securement and dressing change protocols based on the devices being used?
I think that the simple answer is absolutely yes.
Okay. Well, you did give us a lot of information to support that. We also have a question from Susan, who wants to know if you have recommendations for stabilization of IJ-CVADs.
There isn't a lot of literature out there, speaking specifically to that. We certainly do know that they're a very difficult catheter to stabilize. There are some specific dressing products out there that are designed to better stabilize and reduce the loss of the dressing at that site. When I talked about the subcutaneous devices, that are primarily used with PICCs, but they have also been used with internal jugular catheters as well. I think it's probably one of the most challenging areas in terms to stabilize, certainly due to the movement of the patient's neck, the potential sweating, and these patients may have, possibly a tracheostomy or other devices as well. So it is challenging, but I do know there are some specific dressing products out there that are designed to better stabilize that dressing and secure that internal jugular vein. So I think that's worth taking a look at.
Thank you. Lisa, we've gotten several questions from our attendees on the risks associated with the subcutaneous ESDs, and do they potentially have the same kind of risks as using sutures, and what would you have to say about that?
Yeah, that's actually a very good question, and it's been one of my concerns. And I've actually, posed that question, to the company. Apparently that has not been a concern. I think that we don't have a lot of research data out there, but we are having, there is some data that's unpublished, I've heard in presentations, where this particular product has been very successful, and there certainly has not been any increase in bloodstream infections associated with that. And I don't want to quote the one presentation because I don't have that in front of me. I don't have the abstract in front of me, but I think that's a question that many people have. And of course, that's the product that I really don't have familiarity with because it's just not used in my region. There perhaps are some people on the call that really are quite comfortable with it and use it. Like I say, the study that I pulled, the recent study, really looked at, time to dressing replacement with this use, and it certainly is faster and allows for fairly easy site care and dressing replacement, but there needed to be some attention to the pain management. I just haven't seen anything really specific, but I think it's a very good question.
And we do have one of our attendees, Athena, who says those devices are awesome and they use them on PICCs and midlines. So she wanted to share that with us.
That's great. I appreciate that. I haven't heard anyone talk about midlines, at least in the literature, so that's interesting that they're using them on midlines as well.
We have several questions from our attendees looking at wondering about MARCI, and should tincture of benzoin not be used with an adhesive product, and what is the potential for developing MARCI with tissue adhesives?
Actually, that is a potential question. I haven't seen anything, associating the use of a barrier solution, with a tissue adhesive. From what I can see, they're pretty well tolerated, the tissue adhesives. They're designed for that. So I honestly don't really know the answer to that question without any literature to support that. There certainly is the concern has been presented that you really need to know what you're doing if you're removing that catheter early and that adhesive is still really intact. You want to use an adhesive removal product so we're not causing any kind of skin damage as we kind of remove the line and disconnect the drop of tissue adhesive or glue at that site.
Thank you. Nicole wants to know, what do you mean by joint stabilization and post-insertion of VADs?
Okay. When we talk about joint stabilization, I know a lot of people don't like to do this, to use any type of arm board or anything, but that's what we're really talking about. That if, I would say, going back to INS standards and all that we know out there about, risks for extravasation and infiltration, it is increased when we place a peripheral IV in particular in an area of flexion, such as the wrist. Just normal movement. There you have a lot of pistoning of that catheter within the vein, and that is going to predispose that patient to, phlebitis, perhaps infiltration, extravasation. Same with the antecubital area. We really want to preserve those veins and not use it. There's a lot of movement there that can result in complications. So that being said, we know that, no rule is 100% all of the time, and any vascular access device must be placed with care and attention to reducing complications. If we absolutely have to put that catheter in an area of joint flexion, we do recommend a use of a stabilization device such as an arm board. There's a number of products out there. We don't like to use them long term from a range of motion standpoint, but sometimes we would need to, and that will reduce your risk of that pistoning movement that can lead to the complications.
Great, thank you. Kelly wants to know, do you recommend securement devices for short peripheral catheters?
Well, we do recommend, a securement device for short peripheral catheters, but as I talked about that last research study, the large randomized controlled trial, they did not find superiority with any specific product over just a standard transparent dressing. So that was a very interesting finding. I think in general, I would recommend use of some type of securement device, but we want to be cost effective as well. And sometimes if we're looking, and I didn't get into this in the presentation, but if we look at, site selection, say we're placing that, we're avoiding the hand and avoiding the wrist and placing that catheter in the forearm, for example, we can get very good stabilization in that area because it's not being affected by movement. So that's going to be another factor as well. But like I say, this last study was really kind of, surprising that we didn't find superiority with specific products. But I think the, evidence is yet to be done. More studies have yet to be done. We certainly don't want these catheters to be inadvertently dislodged. Again, going back to that patient perspective, if that comes out or we have complications, it really affects them because we have to potentially place another line in them and the pain and discomfort associated with that, as well as the treatment of the complication.
Mm-hmm. Lisa, we had a couple of questions on preterm infants and catheters in the NICU. And are you familiar with any studies about them using glue on umbilical catheters or PICCs used in the NICU?
I am not at this point. I mean, that's certainly an area that's outside of, my expertise. But, as I reviewed the literature, and not that this was an absolute comprehensive review of every study out there, I did not come across anything specific, but it's not to say that there might be something out there. I think I exhausted all of the studies that I could find on tissue adhesives. But I know that there are some pilot studies looking specifically at pediatrics and neonates, and these are coming out of Australia as well. But they're not, there's no final results there. So they are looking at that, and I thank them for doing that. So there will be more data to come in that area.
Great. Christina wants to know, do you perform two-person dressing changes to increase compliance with mandatory dressing changes according to policy and procedure?
Well, we don't, except we don't have any mandatory two-person dressing change procedures. Now, certainly if there's any specific difficulties, we may have two people do that. I don't know. I don't believe that any of the hospitals in my area have that as a mandatory requirement. I know sometimes with our pediatric patients, we will need to send two people out, or alternatively, we may have that done in outpatient where two nurses may be involved in changing that on a pediatric patient, especially those with difficult venous access. So I do see that as a practice in some areas. I don't see it as an absolute mandatory, though. Perhaps other people in the audience, do have that. I'm just not seeing it here.
And Lisa, is there one ESD you'd recommend over another for those patients that may be confused or have a tendency to pull out their lines, especially those that have PICCs and midlines?
I don't know that I really have the optimal solution there. I have not had current clinical experience, although very interested in using the tissue adhesives. I don't know that that would be an absolute solution either, for that patient that is going to, be pulling at their line. They can be pulled out despite the best practices that we do. I think, when we talk about site protection in the INS standards, and this is the kind of population we're speaking to, is there some way of kind of hiding it and making it less obvious, whether we're using some type of, mesh, surgical mesh dressing over it so it's less visible to that patient. I've also heard, in longer term patients where, placement is done in a way that that the patient can't get at it so easily. There are some site protection products out there. But this is a dilemma, but I think a lot of it is, can we somehow distract them and hide it from their view so they're less likely to pick at that?
Mm-hmm. And Kimberly wants to know, because that radial arterial lines are in a point of flexion, is there any data that advocate for the use of an arm board or other such device to improve longevity?
It's a very good question. I did not see anything, and I really tried to search out data and information on radial artery catheters and research-wise, and there's just really very little specifically written about stabilization. So I think that you certainly, could make a case for that, in a short-term situation, because usually they're only in for a day or so in a unit if that patient is really, moving a lot. So a lot of it will depend on the condition of your patient as well in that ICU unit.
We just have time for one last question, and I'm sorry we couldn't get to them all, and I do appreciate everybody's participation. Lisa, how do you audit central line dressing changes and improve compliance to decrease CLABSI?
Well, it's going to depend on your setting out there. We, in my organization, and we take care of many long-term lines, particularly PICS, shorter-term midlines, and we have very strong competencies in place, to monitor that, and we also, have a data reporting system where any, problems are recorded, and we report any CLABSIs through a system that we use in my organization. We just don't see a lot. I think that, it's really going to be dependent on the organization and how they handle that. I've seen some research studies that look at, quality improvement, and I remember one off the top of my head here where they actually use like report cards for the nurses looking at various aspects of care through observations, as well as looking in the medical records in terms of, how things were documented as well. And they provided the nurses with their so-called report card of where they were at in terms of basic care and maintenance for the central line. And ultimately were able to improve some of their processes and overall, adherence to organizational policies for managing the line.
Well, thank you so much, Lisa, and I want to thank everybody who have participated and listened to today's presentation, and hope that this information is really going to help you in your everyday practice. So at this time, I'd like to turn this over to Emily so she can close things up. Thank you all.
And I'd like to thank you very much for your time, both Lisa for this very informative presentation, and as well to you, Mary, for being our moderator today. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.